Hello, in this video, I'm going to talk about the chapter number 19, which is cardiac muscle, the heart as a pump, and the function of the heart valves. We have talked about this chapter in two lectures. One was about the heart, and the other one was about the heart and the action potential, and the other one was about the cardiac cycle. So, come to page number 110, and under the heading action potential in cardiac muscle. See the second paragraph. At least two major differences between the membrane. Highlight the paragraphs which I am speaking. At least two major differences between the membrane properties of cardiac and skeletal muscle account for the prolonged action potential and the plateau in the cardiac muscle. First, the action potential of skeletal muscle is almost caused entirely by the sudden opening of large number of fast sodium channels and allow tremendous number of sodium ions to enter the skeletal fiber from the ECA. These channels are called fast channel because they remain open for only a few thousand of a second and then abruptly close. At the end of this closure, repolarization occurs and the action potential is over within another thousandth of a second. In cardiac muscle, the action potential is caused by opening of two types of channels, the same voltage activated fast sodium channels and another entirely different population of L-type calcium channels, that is slow calcium channels, which is also called calcium sodium channel. This second population of channels differ from the fast sodium channels in that they are slow to open, and even more important, they remain open for several tenths of a second. During this time, a large quantity of calcium and sodium ion flow through these channels into the interior of the cardiac muscle fiber, and this activity maintains a prolonged period of depolarization, causing the plateau in the action potential. Further, the calcium ions that enter during the plateau phase activate the muscle contractile process, whereas the calcium ion that cause skeletal muscle contraction are derived from the intercellular sarcoplasm reticulum. The second major functional difference between cardiac muscle and skeletal muscle that help account for both the prolonged action potential and its plateau is immediately after the onset of the action potential, the permeability of the cardiac muscle membrane for potassium ion decreases about 5-fold, an effect that does not occur in skeletal muscle. This decreased potassium permeability may result from the excess calcium influx to the calcium channels. Regardless of the cause, the decreased potassium permeability greatly decreases the outflux of positively charged potassium ion during the action potential plateau and thereby prevent early return of the action potential voltage to its resting level. Highlight till here. Now come to the page number 111 and highlight the last paragraph, that is refractory period of cardiac muscle. Cardiac muscle, like all excitable tissue, is refractory to restimulation during the action potential. Therefore, the refractory period of the heart is the interval of time during which a normal cardiac impulse cannot re-excite an already excited area of cardiac muscle. The normal refractory period of the ventricle is 0.25 to 0.3 seconds, which is about the duration of the prolonged plateau action potential. There is an additional relative refractory period of a 0.05 second during which the muscle is more difficult to excite than normal, but nevertheless can be excited by very strong excitatory signal. Highlight till here. Now come to page number 112. Highlight the second paragraph. As is true for skeletal muscle, when action potential passes over the cardiac muscle membrane, the action potential is spread to the interior of the cardiac muscle fiber along the membranes of the T-tubule. The T-tubule action potential in turn act on the membranes of the sarcoplasm tubule to cause release of calcium ion into the muscle sarcoplasm. In another few thousandths of a second, these calcium ions diffuse into the myofibrils and catalyze a chemical reaction that promotes sliding of the actin and myosin filaments along one another, which produces the muscle contraction. Let's come to the next paragraph. In addition, that is third line of this paragraph, in addition to the calcium ion that are released into sarcoplasm from the cisternae of the sarcoplasm reticulum, calcium ion also diffuse into the sarcoplasm from the T-tubules themselves at the time of the action potential, which open voltage-dependent calcium channels in the membrane of the T-tubule. Calcium entering the cell then activate calcium release channels called ryanodine receptor channels, triggering the release of calcium in the sarcoplasm. Calcium ion in the sarcoplasm then interact with troponin and initiate cross bridges formation and contraction by the same basic mechanism that was discussed related to skeletal muscle. Highlight till here. Highlight the next paragraph. Without the calcium from the T-tubule, the strength of cardiac muscle contraction would be reduced considerably because the sarcoplasm reticulum of cardiac muscle is less well developed than that of the skeletal muscle and does not store enough calcium to provide for the full contraction. Just highlight till here. The strength of contraction of cardiac muscle depends on the great extent on the concentration. The next paragraph. The strength of contraction of cardiac muscle depends to a great extent on the concentration of calcium ion in the extracellular fluid. Highlight till here. This was all that we discussed in one lecture. So highlight till here. Now come to the next page, that is the cardiac cycle. Highlight the heading, the cardiac cycle, and the cardiac events that occur from the beginning of one heartbeat to the beginning of the next are called cardiac cycle. Each cycle is initiated by spontaneous generation of an action potential in the sinus node. You must know the location of the sinus node. This node is located in the superior lateral wall of the right atrium near the opening of the superior vena cava. And the action potential travels from here rapidly through both atria and then through the AV bundle into the ventricle. Just highlight till here. Then continue highlighting. Because of the special arrangement of the conducting system from the atria into the ventricle, there is a delay of more than 0.1 second during passage of the cardiac impulse from the atria into the ventricle. This delay allows the atria to contract ahead of ventricular contraction, thereby pumping blood into the ventricle before the strong ventricular contraction begins. Thus, the atria act as a primer pump for the ventricles, and the ventricles in turn provide the major source of power for moving blood to the body vascular system. Highlight till here. Already talk about the diastole and systole and the duration as well in the slides, and no need to highlight any other thing from this page. Now let's move to the next page. Relationship of the electrocardiogram to the cardiac cycle. We've already talked about this. The next heading, atrial function is primer pump for the ventricles. Then there is a blue box, the pressure changes in the atria. We've already talked about this. This is the JVP, alright. Okay, start highlighting under this heading, function of the ventricle as pump. The ventricle filled with blood during diastole. During ventricular systole, large amount of blood accumulate in the right and left atria because of the closed AV valve. Therefore, as soon as the systole is over and the ventricular pressure fall again to the low diastolic value, the moderately increased pressure had developed in the atria during ventricular systole immediately push the AV valves open and allow the blood to flow rapidly into the ventricles. And this period is called the period of rapid filling of the ventricles. The period of rapid filling lasts for about first third of the dystole. In the middle third of the diastole, only a small amount of blood normally flow into the ventricle. This is blood that continue to empty into the atria from the vein and pass through the atria directly into the ventricles. During the last third of diastole, the atria contract and give an additional thrust to the inflow of blood into the ventricles. This mechanism accounts for about 20% of the filling of the ventricles during each heart cycle. Highlight all these three paragraphs. Already talk about the isovolumetric contraction, the period of ejection, and the isovolumetric relaxation. No need to highlight anything from here. And we have already talked about end diastolic volume, end systolic volume, and the stroke volume. No need to highlight anything from here. Then the next heading is the heart valve that prevent the backflow of blood during systole. Highlight the atrioventricular valves, the AV valves, the tricuspid and the mitral valves prevent backflow of blood from the ventricles to the atria during systole. And the semilinear valves that are aortic and pulmonary artery valves, they prevent the backflow from the aorta and the pulmonary arteries into the ventricles during diastole. These valves close and open passively. That is, they close when a backward pressure gradient pushes the blood backward, and they open when a forward pressure gradient forces the blood in the forward direction. For anatomical reasons, the thin AV valves require almost no backflow to cause closure, whereas the semilinear valves require a rapid backflow for a few milliseconds. Highlight till here. Highlight this paragraph, the function of the papillary muscle. Papillary muscle that attached to the veins of the AV valves by the chorda tendineae. The papillary muscle contract when the ventricular walls contract, but contrary to what might be expected, do not help the valves to close. They pull the valves inward out towards the ventricle, prevent their bulging too far backward toward the atria during ventricular contraction. If a chorda tendineae become ruptured, or if one of the papillary muscle become paralyzed, the valve bulges far backward during ventricular contraction, sometimes so far that it leaks severely and results in severe, even lethal cardiac incapacity. Aortic and pulmonary artery valves. The aortic and the pulmonary artery semilinear valve function quite differently from the AV valves. The high pressure in the arteries at the end of systole cause the semilinear valves to snap close, in contrast to a much softer closure of the AV valves. Second, because of smaller opening, the velocity of blood ejection to the aortic and pulmonary valve is far greater than that to the much larger AV valve. Because of the rapid closure and rapid ejection, the edges of the aortic and the pulmonary valve are subjected to much greater mechanical abrasions than are the AV valves. Finally, the AV valves are supported by the chorda tendineae, which is not true for the semilinear valves. Highlight till here. No need to highlight anything from the aortic pressure curve. Then see this blue box, relationship of the heart sound to heart pumping. When listening to the heart with a stethoscope, one does not hear the opening of the valve because this is a relatively slow process that normally make no noise. However, when the valve closes, the veins of the valves and the surrounding fluid vibrate under the influence of sudden pressure changing, giving off sound that travel in all directions through the chest. Then the next paragraph, when the ventricles contract, One first hears a sound caused by closure of the AV valves. The vibration pitch is low and relatively long lasting and is known as the first heart sound. When the aortic and the pulmonary valve close at the end of systole, one hears a rapid snap because these valves close rapidly and the surrounding vibrate for a short period. This sound is called the second heart sound. Just highlight till here. To read work output of the heart. No need to highlight anything from the graphical analysis of the ventricular pumping. Then come to page 119 and see the heading regulation of heart pumping. Highlight when a person is at rest, the heart pump only 4 to 6 liters of blood each minute. During strenuous exercise, the heart may be required to pump 4 to 7 times this amount. The basic mean by which the volume pumped by the heart is regulated are intrinsic cardiac regulation of pumping and the control of heart rate and strength of heart pumping by the autonomic nervous system. Then in next paragraph, intrinsic regulation of the heart pumping, the Frank-Starling mechanism. Highlight the second line. The amount of blood pumped by the heart each minute is normally determined almost entirely by the rate of blood flow to the heart from the veins, which is called venous return. That is, each peripheral tissue of the body control its own local blood flow and all the local tissue flow combine and return by way of the veins to the right atrium. The heart in turn automatically pumps this blood into the artery so it can flow around the circuit again. The intrinsic ability of the heart to adapt to increased volume of inflowing blood is called the Frank-Starling. Frank-Starling mechanism means that the greater the heart muscle is stretched during filling, the greater is the force of contraction, the greater the quantity of blood pumped into the aorta. Just highlight till here. Highlight any other point in this page. Now let's come to the next page, that is page number 120. The mechanism of excitation of the heart by the sympathetic nerve. Strong sympathetic stimulation can increase the heart rate in young adult human from normal of 70 to 120, 180 to 200, rarely even 250 beats per minute. Sympathetic stimulation increases the force of heart contraction to as much as double the normal rate, thereby increasing the volume of blood pump, increasing the ejection pressure. The sympathetic stimulation can increase the maximum cardiac output as much as 2-4 to 3-4 in addition to the increased output caused by Frank-Starling mechanism. Conversely, inhibition of the sympathetic nervous system to the heart can decrease cardiac pumping to a moderate extent. Under normal conditions, the sympathetic nerve fiber to the heart discharge continuously at a slow rate that maintains pumping at about 30% above that with no sympathetic stimulation. Therefore, when the activity of the sympathetic nervous system is depressed below normal, both the heart rate and the strength of ventricular contraction decrease, thereby decreasing the level of cardiac pumping as much as 30% below normal. Now let's highlight the next heading. The parasympathetic vagal stimulation reduces the heart rate and strength of contraction. Strong stimulation of the parasympathetic nerve fibers in the vagus nerve to the heart can stop the heartbeat for a few seconds, but in the heart usually escape and beat at a rate of 20 to 40 beats as long as the parasympathetic stimulation continues. In addition, strong vagal stimulation can decrease the strength of heart contraction by 20 to 30%. The vagal fibers are distributed mainly to the atria and not much to the ventricle, where the power contraction of the heart occurs. This distribution explains why the effect of vagal stimulation is mainly to decrease the heart rate rather than to decrease greatly the strength of heart contraction. Nevertheless, the great decrease in heart rate combined with a slight decrease in heart contraction strength can decrease pumping 50% or more. The next page, that is page number 121, and highlight effect of potassium ion. Excess potassium in the ECF cause the heart to become dilated and flaccid and slow the heart rate. Large quantity of potassium can block conduction of cardiac impulse from the atria to the ventricle through the AV bundle. Elevation of potassium to only 8 to 12 milligram per liter, 2 to 3 times normal value, can cause severe weakness of the heart, abnormal rhythm and death. These effects result partially from the fact that a high potassium concentration in the ECF decreases the resting membrane potential of the cardiac muscle fiber. That is, high ECF potassium concentration partially repolarizes cell membrane, causing the membrane potential to be less negative. As the membrane potential decreases, the intensity of the action potential also decreases, which makes the contraction of the heart progressively weaker. Then see the effect of calcium ion. Excess calcium causes effect almost exactly opposite, causing the heart to move towards spastic contraction. This effect is caused by direct effect of calcium ion to initiate the cardiac contractile process. Deficiency of calcium ion causes cardiac weakness, similar to the effect of high potassium. Fortunately, calcium ion level in the blood normally regulated within a very narrow range. Therefore, cardiac effect of abnormal calcium are seldom of clinical concern. Effect of temperature on heart function. Increasing body temperature, such as which occur when one has fever, greatly increases the heart rate. Sometimes to double the normal rate. Decreased temperature greatly decreases the heart rate, which may fall to as low as few beats per minute when a person is near death from hypothermia. These effects result from the fact that heat increases the permeability of the cardiac muscle to ions that control heart rate, resulting in excitation of the self-excitation process. Highlight till here. For chapter 9, I hope you understand this. Integrate this lecture with the slides and with the discussion we had in the lecture. Thank you for listening.